afternoon, and welcome to Internal Medicine Grand Rounds. There is no commercial support for today's program. The speaker and planners have disclosed no relevant financial relationships with any commercial interest. If you have a question for our presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A section. Also, a link to the event survey will be shared at the end of the program. It is my pleasure to introduce Dr. Sarah Ross. Dr. Ross is a third-year internal medicine resident physician here at Northeast Georgia Medical Center. She holds a Bachelor of Arts degree she received from Cornell University, where she studied biology. Subsequently, she attended Marian University School of Osteopathic Medicine in Indiana, where she received her Doctor of Osteopathic Medicine. At Northeast Georgia Health System's Internal Medicine Residency Program, she is a member of the Primary Care Track, which focuses on a comprehensive curriculum aimed at improving ambulatory care skill sets. Her career goals are to practice primary care in the Denver, Colorado area. Join me in welcoming Dr. Ross.
All right, thank you so much. So my topic today is advancements in LDL lowering therapies, exploring beyond statins. No disclosures. So by the end of my presentation, we should be able to outline the benefits and disadvantages of statin therapy, define statin intolerance, review pleiotropic effects of statins, compare and contrast non-statin LDL lowering agents, and discuss upcoming treatments and advancements in lipid management. So starting off with a little bit of the history of statins. So as we know, statins have long been a cornerstone of lipid-lowering treatment. Some of their advantages are their relatively low cost and dosing in the form of a daily pill. They have been shown in multiple studies to have effectiveness in lowering low-density lipoprotein cholesterol, or LDL. Reduction in LDL levels has also been independently linked to decreased risk of adverse cardiovascular outcomes, such as strokes and myocardial infarctions. A 40-point LDL reduction can lower risk of cardiovascular events by over 20%, so pretty big impact. So statins and pleiotropism. So pleiotropism is essentially when a medication has an effect outside of its originally intended purpose. Both LDL-dependent and LDL-independent or pleiotropic effects are seen with statin medications. High statin dose medications, in particular, have been shown to have significant benefits in reduction of atherosclerotic plaques. Apart from intensive LDL lowering effects, multiple studies have also demonstrated that statins also have anti-inflammatory properties. So starting off with the Jupiter trial, so it investigated whether statins could prevent first-time cardiovascular events with elevated CRP, but LDL levels below treatment guidelines. So this was important because it investigated groups that were not traditionally indicated to have statin medications because their LDL levels were below or at the normal level. The hypothesis behind this trial was based on evidence that inflammation plays a key role in atherogenesis and that elevated CRP may independently predict vascular events regardless of LDL levels. The study findings ultimately suggested that rosuvastatin, which is the statin that was used in the study, significantly reduced cardiovascular events even in this lower LDL group. This trial was important because it supported the benefits of primary prevention in populations not traditionally considered high risk, so with lower normal LDL levels and increased CRP levels. The Jupiter trial also showed another more disadvantageous pleiotropic effects of statins that was suggested, which is an increased possible risk of diabetes. So the results indicated possibly statins increasing risk of new onset diabetes in patients who were initially treated with new onset statins. This was a higher likelihood if they also had pre-existing risk factors. Nevertheless, overall cardiovascular benefits of statins for primary prevention still outweigh this risk of developing diabetes. Other studies since that time have shown that high-intensity statins are more frequently associated with increased type 2 diabetes risk, implying a possible dose-dependent mechanism. However, the mechanism behind which statins can cause increased risk of diabetes has not been shown yet, and there are obviously a lot of confounding variables because those who are started on statins may already have pre-existing risk factors for diabetes. Here I have a case vignette. So a 75-year-old woman with hypertension presents with new onset AFib and is hospitalized. At home, she was on diltiazem, 240 milligrams, and her blood pressure on presentation was 135/85. Heart rate was 70 beats per minute and irregular, and her BMI was 22. Abnormal lab values were lipid profile with a total cholesterol of 305, triglycerides of 250, HDL of 35, and LDL of 220. She was discharged on diltiazem 180 grams, amiodarone 200 milligrams, and simvastatin 40 milligrams daily, so started on a new statin medication. 3 weeks later, she presented to the ED with severe muscle pain and weakness and rusty-colored urine. Her blood pressure at that time was 98/60, heart rate was 85 beats a minute, and her labs now revealed total cholesterol of 198, triglycerides of 200, HDL of 32, and LDL of 154, so decrease overall in her cholesterol levels. However, her creatinine kinase is 12,000 and urine is positive for myoglobin. Which of the following statements is true? So I'll go through the different responses here. So A, simvastatin was an appropriate choice. If her diltiazem dose was reduced, there would be no drug-drug interaction. B, the patient should never be given any statin at any dose after this episode of rhabdomyolysis. C, there are other characteristics about this patient that place her at high risk for statin-induced muscle complications other than a drug-drug interaction. And D, in general, all statins may be associated with muscle-related symptoms, but simvastatin, atorvastatin, lovastatin, and rosuvastatin have the highest incidence because they are metabolized by cytochrome P450 system in the liver. So does anyone in the audience know which answer it is or would like to suggest an answer?
Yes, hold on. Let me phone a friend. We're going D as in dog.
Was it all true? No, it's D.
So the answer is actually C.
Oh, C.
So the reason behind this is that the case is just specifically more focusing on risk factors for drug-drug interactions with statins. So in this case, because she's an older age female and has a lower body weight, that places her at increased risk of statin intolerance. Other risk factors that were not mentioned in the case are alcohol use, vitamin D deficiency, and rheumatologic disease can also be associated with some statin intolerance as well. So specifically focusing more on kind of the point that Dee addressed is the medication side effects. So examples of medications that increase statin side effects are certain calcium channel blockers, such as diltiazem in this case, but also antifungals such as azoles and antibiotics such as erythromycin. These medications can inhibit the cytochrome P450 system, and certain statins such as simvastatin, atorvastatin, lovastatin, and rosuvastatin are not metabolized as well and therefore have higher risk of side effects. So starting off with the definition of statin-induced myalgia. So the definition is having symmetric, proximal, large muscle pain or weakness. Specifically, symptoms begin 2 to 4 weeks after statin initiation and stop 2 weeks after discontinuation. Symptoms then usually return within 2 weeks after reintroducing statins. Lastly, symptoms with 2 or more different statins prescribed at the lowest dosage would have you meet criteria for this. Then specifically, the definition from the National Lipid Association on statin intolerance, which is a little bit different than statin-induced myalgia, is defined as one or more adverse effects with statin therapy which resolve or improve with dose reduction or discontinuation and can be classified as complete inability to tolerate any dose of any statin or partial intolerance with inability to tolerate the dose necessary to achieve the patient-specific therapeutic targets. Adverse effects of statins in general can include myalgias, and less commonly rhabdomyolysis and liver injury. So essentially, statin-induced myalgia is lower on the spectrum of side effects, and if you have more significant side effects, then you're starting to go into statin intolerance. So the problem that we're facing here is intolerance. So although statins are generally well tolerated, statin intolerance or perceived intolerance is frequently seen. As I mentioned, intolerance can exist on a continuum, but most patients can actually tolerate some degree of statin therapy even if they have symptoms. Despite this, adjustments often need to be made, and discontinuation or modification of treatment can sometimes lead to suboptimal cholesterol control. Patient adherence is another issue that is faced due to side effects and preventative benefits of medications not being easily noticeable. Although statins still remain the first-line treatment for dyslipidemia, adherence rates can be as low as 50% within 1 year of starting therapy. Poor adherence has also been associated with higher risk for adverse cardiovascular outcomes. So what's the solution? Option 1. Patients on maximally tolerated statin therapy with consideration of lower intensity statins and or less frequent dosing. So basically trying to have patients be on as much statin medications as they can possibly tolerate, and spacing out dosing to decrease the number of side effects. Option 2 is non-statin LDL lowering agents as an adjunct, or if needed, an alternative to statin therapy, which is the main focus of the talk today. So knowledge check question. For statin-induced myalgia, when do symptoms usually return after restarting statin?
We're going to go 2 weeks?
That's correct.
Yay.
So this is kind of a big slide here, but it's essentially an overview of all the different mechanisms of multiple non-statin agents that we will be talking about throughout the lecture. So beyond statins. So these are the medications that, the main medications that are the non-statin LDL lowering agents that we'll be discussing today: ezetimibe, bempedoic acid, bile acid sequestrants, and PCSK9 inhibitors. But first, I want to give a little bit of background about the current LDL management guidelines. So the 2018 AHA-ACC guidelines suggest that for patients not at very high risk of ASCVD, if they're on maximally tolerated statin therapy, then you should consider adding ezetimibe if they do not meet LDL targets at that point. If they're in the very high-risk ASCVD group and are already on high-intensity or maximally tolerated statins, you should consider adding ezetimibe before initiating PCSK9 inhibitors. So another guideline per the 2022 ACC, it's more of an expert consensus. So they specifically focused on high-risk patients on statin therapy for secondary prevention. So if they did not meet goals, consider optimizing lifestyle modifications, increase to high-intensity statins, and if they're still not at goal, at that point consider adding ezetimibe and or PCSK9 inhibitors. Also, if they're still not meeting their target goals, there's other agents as well, such as bempedoic acid or inclisiran, which we'll be discussing later. Just wanted to give a perspective on the European guidelines as well. These are from the 2023 European Society of Cardiology. So number one is that they say that older adults with ASCVD should actually be treated the same as younger patients, especially if they're at high risk. And this was specifically focusing on age greater than 75 populations. Number two is no known adverse effects are linked to very low LDL levels. Therefore, high-risk patients should have lower LDL goals. True statin intolerance is rare. Therefore, consider maintaining treatments in patients with statin-associated muscle symptoms. And then 4, starting lipid-lowering therapies such as high-dose statin monotherapy or combination therapy with statins plus ezetimibe and PCSK9 inhibitors in acute vascular events appears to be beneficial. So jumping into the different agents. So ezetimibe has a mechanism which reduces cholesterol absorption by specifically inhibiting a transmembrane protein at the brush border of the small intestines. In turn, this results in upregulation of LDL receptors and increased cholesterol clearance from the bloodstream. An important trial for ezetimibe is the IMPROVE IT trial, which showed that in combination with statin therapy, it resulted in incremental lowering of LDL cholesterol levels and improved cardiovascular outcomes. And in practice, this medication is often used as an adjunct to statins to achieve lower LDL goals in those patients on maximally tolerated statin therapy. Next up is bempedoic acid. So this mechanism of this drug is a prodrug that needs to be converted by a liver enzyme to its active form. So it acts on the same pathway as statins to stop cholesterol synthesis. However, the benefit of this medication is that the enzyme only acts in the liver and not in the muscle cells. That's why it may be a better option for those patients who are intolerant of statins because of muscle side effects. Warning, may cause elevated uric acid. Mean reduction in LDL therapy in combination with statin therapy can be 17 to 18%. An important trial for this medication is the CLEAR Outcomes trial. So in those patients who are statin intolerant, it was associated with a lower risk of major adverse cardiovascular events. Up next are bile acid sequestrants. So colesevelam, cholestyramine, which is kind of our main one, and then cholestyramine are the 3 main bile acid sequestrants. The mechanism is to absorb bile acid in the intestines, impede their reabsorption, which leads to upregulation of a pathway of enzymes, ultimately increasing clearance of LDL from the blood. Common side effects are bloating, constipation, and, important to note, hypertriglyceridemia. A trial for this medication is the coronary prevention trial, specifically for cholestyramine. So this was done in middle-aged men, and it lowered LDL by around 11%. This resulted in a 19% reduction in non-fatal and 24% reduction in fatal myocardial infarctions, with no change in all-cause mortality. The effects of the other 2 bile acid sequestrants on cardiovascular outcomes have, however, not been determined. Jumping into another big category here is the PCSK9 inhibitors. So the one that we more commonly talk about are the 2 monoclonal antibodies, alirocimab and evolocimab. And then another category, which is a little bit lesser well known, are small interfering RNAs, mainly inclisiran. So starting off with the monoclonal antibodies. So important trials for the 2 different antibodies are the Odyssey trial for alirocimab and the Fourier trial for evolocimab. They both showed a 15% relative risk reduction in cardiovascular events when used as an adjunct to statins. Common side effects for evolocimab are headaches and nasopharyngitis, and alirocimab are injection site hypersensitivity reactions. Another advantage is that they're both given as bi-monthly injections, so less frequent dosing. Another PCSK9 inhibitor is inclisiran. So this works actually as a small interfering RNA that disables PCSK9 mRNA transcription for more than 6 months, leading to longer lasting LDL reduction. Subcutaneous dosing is on day 1, 90, and then every 6 months. Most common side effects are injection site reactions and antibody development. So advantages here is that the dosing is less frequent, but these agents are still expensive, so that's a downside. Jumping into the Orion 10 and 11 trials. So this one's not named after a planet, but a constellation. reductions in LDL cholesterol levels of approximately 50% were obtained with inclisiran, administered subcutaneously every 6 months. So there's still some follow-up trials in development with Orion 4 expected to have results in 2026, and then another trial, Victorian, expected to have results in 2027. So kind of brief aside, just wanted to cover some of the inherited lipoprotein disorders and non-statin treatments for them. So for homozygous familial hypercholesterolemia, lamipitide targets very low density lipoprotein, and vanisab is a monoclonal antibody with LDL receptor independent mechanism of action. Another option is lipoprotein apheresis, which I kind of think about as dialysis for lipids, which can also be an effective option as well. Knowledge check question. What is a possible side effect or warning associated with bempedoic acid? There you go. Hard questions, I know. Okay, so what's up next? So investigational therapies that are still in development are CETP inhibitors, which is a third generation PCSK9 inhibitor. This is a small recombinant fusion protein. This is an oral PCSK9 inhibitor. And then also gene editing is being looked into to restore or disrupt specific genes at the DNA level. So conclusions. So in general, as I kind of went through the different guidelines, we're continuing to trend towards lower LDL targets for cardiovascular disease prevention, with updated ACC-AHA guidelines expected in the first quarter of 2026. Number 2, statins are still first line for LDL lowering therapy, but non-statin adjuncts should be considered when statins alone are insufficient or not well tolerated. Number 3, lower intensity statins and or less frequent dosing may be options for those patients who are statin intolerant. Number 4, so link between statins and increased diabetes risk still requires further study to understand the underlying mechanism, but given their strong cardiovascular benefits, as of now, advantages of treatment still likely outweigh risk. Inflammation plays a key role in atherosclerotic plaque formation, making therapies with both lipid-lowering and anti-inflammatory effects potentially more beneficial. So future of lipid management lies in combination therapies, as emergent treatments could help achieve lower LDL targets and improve cardiovascular outcomes beyond maximally tolerated statin monotherapy. Something that I didn't discuss specifically in the PowerPoint is there has been some research into PCSK9 inhibitors, potentially also having some anti-inflammatory effects specifically within the plaque itself. So my references. Special thanks to Drs. Gross, me, Subramaniam, and Umana. Thank you for your help. This is kind of fun. If you couldn't tell, I like astronomy. So I included here, this is a heart nebula. So it's a reminder for us to keep cholesterol low and hearts plaque-free. Questions?
Thanks, Sarah, for your presentation. I had a question. When you're going through just preparing for this presentation, did you see anything about fish oils and what role they play in management of lipids?
Not specifically, although bempedoic acid is kind of targeting a similar mechanism, but in general, the main non-statin treatments that were mentioned in most of the studies are the ones that I listed here, but there's still further research being done into fish oils specifically. Oh, and I think that's also a little bit more targeted at triglycerides as well, and I focused a little bit more on LDL lowering therapies for my topic.
Great job, Sarah. This is an important, relevant topic in internal medicine, inpatient, outpatient, and you told it in a smooth flowing manner and an engaging way. When you discuss like initiation, like the recommendations, high risk, low risk, can you just elaborate on how do you initially categorize patients that way? What tools do you use? And then just like any hesitation in prescribing based upon like relative versus absolute risk for patients, and knowing and elaborating on the side effects and the intolerance.
Yeah, so in general, we do usually go off of ASCVD risk in prescribing or trying to categorize patients in the different treatment groups. And based off of that, that's how we kind of make the initial decision to start statin therapy. But there are certain, risk factors that may make you think of starting statin therapy, especially in patients who have kind of more of a borderline ASCVD risk. As I kind of discussed, inflammation is an important factor in the formation of atherosclerotic plaque. So for example, patients who do have inflammatory disorders, rheumatologic disease, would be more likely to be started on statin therapy because of that reason. And then in terms of kind of risk-benefit, weighing whether or not to start statin therapy, I think overall, despite some of the risks that I have discussed, I think having at least some portion of statin therapy in patients is still beneficial because it does have a big impact on lowering LDL. But I think the advantage is that now we have other statin adjuncts that we can use in those patients who may not be able to tolerate high-intensity statins, and so we can have them on a lower intensity or less frequent dosing regimen and still use the adjuncts to achieve lower LDL goals.
Thank you, Sarah, for that presentation. I know you made mention about the risk of diabetes as part of lowering LDL, and I think you kind of gloss over based on the European recommendations that there isn't any downside to low LDL, which kind of contradicts the diabetic risk that can be seen when LDL are being lowered. Because my question now is the risk of diabetes for those who lower LDL, is it associated with the method in which you lower the LDL, such as maybe statin versus PCSK, and of course, understanding that diabetes itself then becomes a risk factor to cardiovascular disease, but then there's still a statement saying that the risk is, I guess, negligible when you are just focused on the cardiovascular risk in itself. So I guess just kind of, looking at statin in itself, it seems to have a lot of more question mark than clarity. I don't know if you found any, clarifications that could kind of help us if it's a, statin in itself or just lowering LDL. And then, of course, the risk factors with the, diabetes, and of course, trying to lower all-cause mortality for cardiovascular risk. Thanks.
Yeah, thank you. That's definitely a very good question. So to clarify, it was the statin medication itself that caused the increased risk of diabetes. So as far as I know, there hasn't been a similar effect found in other medications, although I didn't extensively look into research trials based on that. The mechanism itself is not well understood, but multiple studies have seen a possible association with statin therapy and increased risk of diabetes. So it's not certain whether or not the LDL lowering itself is what is causing the higher risk of prediabetes and diabetes, or if it's just that patients who are placed on statin therapy may already have pre-existing risk factors for diabetes itself as well.
Great presentation, Sarah, Dr. Ross. So the usual cholesterol panels contains, lipid panels, which indirectly measures the cholesterol amount. Have you looked into other biomarkers, apolipoprotein A, LDL particle, and Lp(a), and then their utility in clinic?
Yeah, so that's not something I focused on too much for this presentation specifically. I tried to stay focused just on LDL, but I think some of the genetic treatments especially could be focused on those different biomarkers and other lipid particles. So there's definitely a lot of research being done into that, potential with biologics and gene therapy, kind of addressing those more specifically.
Okay, thank you, Dr. Ross.
All right, thank you.